Thank you for the invitation. And what I hope to do is get you excited about the global burden of disease, which is aimed at being a public good. And I understand from having talked to a few of you that you probably don't know a lot about the study. So I'll give you a brief explanation of what it is about. I'll say a bit more about how we deal with estimating the impact of risk factors on health outcomes, but spend most of my time showing you all the beautiful visualization tools that we have to show you the millions and millions of pieces of data that are being generated as part of this project. So our starting point is to say we think that everyone deserves to live a long life in full health. And what is preventing us from achieving this goal? And so we try to provide a comprehensive picture of what disables and what kills people by country, over time, in great amount of detail by age and by sex. And as a more formal definition of what we do, it's a systematic scientific effort to quantify the comparative magnitude of health loss due to diseases, injuries, risk factors, by lots and lots of detail. We measure health loss, and we call it a health gap measure, against a reference or a normative goal for a population of living in full health with a life expectancy at birth of around 86 years. And that means that because we use a life expectancy approach, that even when you reach age 86, you still have some remaining life expectancy. We use this across all countries in the world because we want to measure every country against the same norm. If we set a norm of what we think is an ideal and we measure where each country is against that norm, then we wouldn't want to use a different norm for a poor country as opposed to a rich country. So this started in the late 1980s and first produced the results for a World Bank report in 1993. But at that time there wasn't any coherent set of figures on the contribution of all these different diseases and injuries and risk factors. At the same time, when one of the people who started this work went round to all the WHO offices and said how many people die from cancer, from road traffic accidents, from malaria, from pneumonia, and added up all the deaths, he had, lo and behold, 2.5 times more deaths than occurred in the whole world. So at the same time, the focus was very much just on mortality at the time, whereas we started to argue that to get a balanced picture on what is important for policy making in health is that you need to look at not just at what kills people, but also what causes non-fatal health outcomes. So all this work went on for quite a while. It was the first time that a more comprehensive measure of health loss was made. It identified important health problems that traditionally were not part of priority lists, like major depression or musculoskeletal disorders. And it also demonstrated that while infectious diseases and other diseases of poverty dominate the burden of disease in low-income countries, they also have their fair share, and often a more than fair share, of non-communicable diseases and injuries. So about 10 years ago, we started rethinking how we do this, because the original work at the global level was done to produce regional estimates. And the real need we identified was for country estimates, and often within countries for subnational estimates. Also, over time, by changing the methodologies, the results were no longer comparable. And so it was hard to examine trends over time. We had also missed out on some of the more important contributors to the burden of disease. And it was all based on a single point estimate, whereas when you do this work, you realize how little we know about many of the bigger health problems, and certainly for some parts of the world, it is not easy to make credible estimates. So we said we need to systematically make estimates with uncertainty. So this culminated in the Global Burden of Disease 2010 study, where we made estimates for 187 countries, and we did a whole time series from 1990 to 2010 using exactly the same method so that we had comparable estimates. 291 diseases and injuries, over 1,000 sequelae or consequences of these diseases and injuries, and 67 risks and clusters of risk factors. We then said, well, we've done this big effort, and it took us, well, we said it would take us 3 years. It took us 5+ years to complete that study. And then we said it'd be a waste to drop it, wait another 5 years, and then do a big effort again. We said there's a need for the most up-to-date information on health in the world to help policymakers. And therefore, the most efficient way is to build on what the big effort that we did for GBD 2010 and to go to a cycle of annual updates. So that's what we're doing currently, and I'll show you the results of the GBD 2013. So this allows us to incorporate new knowledge, new methods where we get new insights on how best to quantify the effects of diseases and any methodological innovations. For instance, we've incorporated new information on the etiologies of diarrhea and pneumonia to change how we estimate those diseases. This is supported by a large network of collaborators, and if you've seen our papers in The Lancet, they have a full page of just author names to begin with, and then all the institutions they belong to. I think that goes on to page 25 or 26 of most of our papers. But they're an invaluable resource, and in particular, we've noted that more intensive collaboration with a number of countries, for instance, with China, with Mexico, with Brazil, where we started making subnational estimates. China is such a big country, we wanted to make estimates by province, helped unearth a large amount of information about diseases and mortality that many people in the world had no idea existed. For GBD 2013, we increased the number of diseases and injuries to 306. Many more sequelae, but that is the big increase there is largely that we started doing all the injuries in a much more fine-grained manner, and that quickly added up the numbers there. A few more risks, but also we've become more savvy at combining different risk factors and being able to present that. South Sudan was added to the list, so we have 188 countries. The 188 is because of a cutoff of a minimum of 50,000 population. So anything else we call the DITSLs, we don't have specific estimates for. This is believe it or not, this is a brief flow chart of the flow of work in the study. There's an element where we estimate just what we call the envelope of mortality from demographic sources, how many people die by age and sex. We then fill in the envelope with all the causes of death, information from vital registration, from verbal autopsy studies, sometimes police records, hospital data, and fit that within the demographic envelope to avoid this problem of individual estimates disease by disease, grossly overestimating what we know is the total number of deaths. It's a whole area of work on the disability side, so disease by disease and consequence of disease by consequence of disease, we collect information, and the aim is to estimate the prevalence of each of these diseases and their consequences, and we attach a severity weight, which we call disability weights, to indicate how severe one health state is compared to another. So a few days with common cold gets a relatively low severity weight, whereas if you have quadriplegia for the rest of your life, that attracts a very large disability weight, and we multiply prevalence by the severity weight, and that's what we call our years lived with disability, and that's the amount of time, healthy time that's being lost due to all these different diseases. For the causes of death, we multiply the numbers of death by the remaining life expectancy from our ideal life table and calculate years of life lost, which is a measure of premature mortality. That means that if you die at age 80 from a stroke, you accrue less years of life lost than when you're a baby who dies from preterm birth complications. So there's no science behind that. This is a choice that we made, that we say most people will value the loss of health in a young person as a greater amount of health loss than the death of a person at an older age. And then maybe more of interest for most of your work is the part of the GBD that works on risk factors, where we have this set of 76 risks, and I'll say quite a bit more in detail about that, where we look at what's the prevalence of exposure to these risk factors, like unsafe water and sanitation, or bad diet, or unsafe sex, or there's a long list of them. What is the risk associated with being exposed to that risk factor, and what fraction of the multitude of diseases for which we make mortality and disability estimates can we attribute to these underlying risk factors? So the way we estimate our diseases and mortality is using the categorical attribution. And so we use this long-cherished tradition in vital registration systems that you get a single underlying cause of death. And similarly, we make estimates for each individual with a particular disease. The nice thing about that is that you can force things to add up to 100%. The hard part is to actually identify what the proper underlying cause of death is. And part of our work is to try to make sense out of all these different ways that different countries and different certifiers in countries deal with this concept of underlying cause of death. And so a large part of our work is to adjust data for biases that we've been able to identify. So we do a lot of redistribution of what we call garbage codes. And some countries are very good at garbage coding of deaths. Others use them very sparingly. And to bring every country on an even, treat them in an equal way, we have to deal with all these idiosyncrasies in order to make the results more comparable. So just as an example, I don't know if you know about the French paradox. It basically says the French totally misbehave in terms of drinking and smoking in their diet, with lots of butter but they still have very low cardiovascular mortality. Yes, that's right, but more than half of the traditional French paradox has nothing to do with lifestyle. It has to do with the fact that certifiers in France use a lot of garbage codes. The second way of doing this is what we call a counterfactual approach. And that's what we do when we attribute burden to risk factors. We ask the question, what would the burden of disease be if we can eliminate or reduce exposure to a risk factor to some theoretical minimum? When you do that, and you have a whole lot of risk factors for which you make estimates, no longer nicely adds up to 100%. And it can actually exceed 100% by quite a margin. In quite a lot of age groups and in countries, if we stack up all the risk factors that affect cardiovascular outcomes, we explain the burden 300-400 times over, 300 to 400%. And that's because a lot of these risks have common pathways or work through each other to affect cardiovascular outcomes. So how do we do the risk factors? First, we need to know what is the distribution of exposures in the population to this risk factor. Then, given exposure, what is the associated risk of which disease? That's what we call a risk outcome pair. So blood pressure and stroke, unsafe water and diarrhea as an outcome. And then we set a theoretical minimum risk exposure. Sometimes that's logical. You can say it's theoretically possible that nobody smokes. So we set a 0 theoretical minimum for tobacco. But you can't do that for blood pressure, because 0 blood pressure is not a very good thing. And so we tend to look at what is the level of exposure that is associated with the lowest amount of the health outcome. Sometimes we observe that, sometimes we get it from trial data. And so risk by risk, and for each outcome, we set this theoretical minimum risk exposure. So for a continuous risk factor, as I mentioned, like blood pressure or cholesterol, we set it at a non-zero level. And I think I've gone over this already. So how do we choose the risks and the outcomes associated with them? First of all, we say there needs to be sufficient evidence for a causal relationship. And we use the sort of cancer world terminology of convincing or probable evidence. And they have very specific criteria for that to estimate effect size. We also need to feel comfortable that from the evidence that you have, that you can generalize this effect size to populations other than those that were included in epidemiological studies. The third criterion is how important or how likely important is this risk factor to disease burden or to policy. So it's either we expect it to be a big chunk of disease burden, or it may not affect disease burden in a great amount of detail, to a large extent, but there's a very big policy interest in the topic area. And we need to have enough data and methods that allow us to make those estimates. For the most recent study, we divided risk factors into 3 broad categories. Category of environmental and occupational risks, behavioral risks, and metabolic risks. The level down is breaking those into a greater number of groups. So all of diet, all the effects of tobacco, including secondhand smoke, all of water and sanitation and hygiene in one category. Then the next level where we have more detailed components such as fruits, nuts, and seeds among diet. And for some, we needed yet another level in our hierarchy for the occupational carcinogens, for instance. So the total of occupational carcinogens is at a level 3, and then each of the carcinogens are at our level 4. And it's important because when we aggregate, we need to stick to this hierarchy. These are all the risks. So there's a range of environmental and occupational risks, a whole list of, you can see here, carcinogens, other occupational exposures, but including also occupational ergonomic factors. And among all the occupational risks, you will see that low back pain is the largest, rather than the traditional focus on a lot of the carcinogens. Unsafe water, sanitation, hand washing, air pollution, which we split into ambient particulate matter pollution and household air pollution, as well as ambient ozone. And we separately make estimates for radon and lead. Then among the behavioral risk factors, there are a range of risk factors around child and maternal nutrition, tobacco, alcohol, and drugs, dietary risks in quite a lot of detail, sexual abuse and violence, unsafe sex and low physical activity, and then a range of metabolic risks, which are more proximal, if you like, in the chain of the causal chain to the outcomes. And for instance, we added low glomerular filtration rate this year to our list of risk factors to capture the cardiovascular outcomes that are associated with poor kidney function. Then for each risk, and I'm just showing you some examples, we identify all the target diseases from the literature and get the appropriate relative risks from systematic reviews. If they hadn't been done, then we do them ourselves, or we update the ones that exist. Then some of the risks are relatively easy computationally. They're dichotomous, a yes or no exposure. And so, for instance, we do that for household indoor air pollution, which is based on census data of what type of fuel is being used in the household, which is a proxy for what we would really want to know. But there are too little data sources that actually measure the levels of pollution in households. But hopefully soon we'll be able to use more continuous measurements of exposures rather than this dichotomous risk. Sometimes, and this is what we've largely been doing in the past, this was done on the metabolic risk, where you artificially say you're hypertensive and you're not hypertensive. We are, as much as we can, shying away from that because from experience, that underestimates the true risk, because there's no all of a sudden start of risk above a certain clinical cutoff. And actually, by the sheer numbers, often the amount of disease risk that's conveyed by people who are below a clinical cutoff is quite significant, if not the dominant part of the burden. Then we have a number of polytomous risks. So we have 7 categories of water and sanitation. I'm showing you here the water categories, where we set piped and treated water as the reference category, and we get relative risks for each of these against the theoretical minimum risk. Same thing with physical activity, we do in 4 categories. And then for the continuous exposures, we look at the lowest value at which any risk is still existing. And so for blood pressure, we say we have no information that a blood pressure systolic blood pressure below 115 conveys any additional benefit. But we do say that a blood pressure of 125 is worse than a blood pressure of 115. And mind you, these are not clinical criteria, these are theoretical minimum risk criteria. The data sources, many of them come from surveys on quite a few of the metabolic risks and the list that you see here. Quite a lot have to come from self-report by just the nature of them. Some of them we can still anchor on other data, like for alcohol and tobacco. We make use of data from the taxmen on how much excise duty they have collected, so that we have an envelope of how much tobacco is being consumed. And with alcohol, we even add in estimates of illegal production of alcohol to get a total amount to which we fit the self-reported data. There's some indirect methods we use for injecting drug use, where we anchor our estimates at the level at which it has been studied in places where they can triangulate between treatment centers and needle exchange programs and the judiciary to get a good total number in the community. I'll show you a bit about our air pollution estimates, which we actually now make based on satellite imagery. I mentioned the trade sales and consumption data for alcohol and tobacco, but we do the same for the dietary risks. We use the ILO database by occupation to get a proxy for what occupational exposures would be, and some of the data comes from census. So let me show you the air pollution. This is the information if you just look at ground measurements. This is a slide, it's a slightly old, but it shows for 2010 what information we had on PM2.5 or PM10. So the particulate matter, and 2.5 and 10 is the size of the small particles. And you can see it covers, just some parts of the world. And what you also don't see is that most of the dots that are here, they are cities. So no measure of or very few measurements of rural areas. So instead what we turn to is satellite-based measures of aerosol optical depth in combination with chemical transport models that can now give us on a 10 by 10 kilometer grid across the globe what the exposure is to PM2.5. We then calibrate this against the ground measurements so that we get a balance between the two. And you can see very large exposure across the belt here from the Sahara and the Gobi Desert, the Middle East and Gobi Desert, into the eastern seashore of China, with a very large amount of industrial pollution. So you can see that deserts contribute a lot to particulate matter.